Well, yeah. Okay, cool. Good morning, everyone. How is everybody today? Good morning and welcome to Nurture Casey's annual meeting, Mind Over Matter, Maternal Mental Health in Casey Metro. Thank you for joining us today in what I know will be a very exciting educational event. My name is Sebren Jensen and I am the board chair of Nurture KC, and I also serve as the director of business development for Women's and Children at Advent. I am specifically passionate about addressing maternal health disparities, so it's an honor to be stepping into this role of board chair for an organization that is leading the charge on better quality outcomes for maternal and infant health. Before we begin today's programming, the annual meeting serves another important purpose, and that is the official transfer of board leadership, election of new board members, and approval of Nurture Casey's bylaws. While members have the opportunity to vote electronically on these matters, I would like to recognize departing and new board members. So if you're here, please stand. Aaron Gabbert, Raylan Casamanio, are leading the Nurture board after providing both their expertise and guidance for multiple years. And neither one of them are here. Okay. My predecessor, Kamara Nini, now is becoming past chair in Nurture Casey board. So I just want to thank them, even though they're not here. Next, please join me in welcoming our 4 new board members. Frank Gray, who I know is here. Yes, Frank. Okay. Connor Strangler, Jimmy Starr, and Elizabeth Simpson. Their enthusiasm and commitment to Nurture Casey ensures a continuum of upward mobility for the agency. Now for some housekeeping items. We have built-in breaks in the agenda. However, please feel free to get up and get food and drinks or use the facilities. All of the snacks in the back are delicious. I've eaten a lot already. The bathrooms are located to the back right. We have included bio information on all of today's presenters and incoming board members attached to the agenda to help save time with all the incredible content that we have planned. This meeting is eligible and overseen by BE Education Group, LLC. So in order to successfully complete this meeting, participants will need to sign the attendance sheet, participate and attend the meeting in its entirety, complete post-program electronic evaluation that will be sent next week by Nurture KC, and a certificate of completion will be available for printing at the end of the survey. The educational activity has been awarded 1.5 nursing contact hours and 1.25 social work CEUs. BE Education Group LLC is an approved provider for continuing nursing education by the Midwest Multi-State Division, an accredited approver by the American Nurse Credentialing Centers Commission of Accreditation. BE Education Group LLC has been approved as a continuing education provider by the State of Kansas Behavioral Health Science Regulatory Board. No conflicts of interest have been identified for the planners or presenters for this educational activity. Okay, now we've got all that taken care of. We now want to begin this educational event with the executive report from Tracy Russell.
Good morning, everybody. Thank you so much for coming. I got to put these on my nose so I can see everybody until I look at my slides. I've come up on 5.5 years here at Nurture KC. It has flown by. And I think what has struck me as I prepared for this meeting and in just the last 6 months or so is the stability of this organization is a hallmark of the organization. But what's also interesting is that we keep evolving. And I think that's particularly true as we talk about the next chapter here and the next iteration of Healthy Start. So we were awarded our new grant. It runs on a 5-year cycle. This just began in May, actually, so brand new. Oops, this is, okay. Yeah, this isn't working. Okay. Whoops, okay. So I want to talk about this grant cycle just a bit. This is still not, okay, there we go. I think my paper's hitting it. So believe it or not, we will have had this program for 30 years. That doesn't mean it doesn't change considerably, and this grant cycle is no exception. So one of the changes is they will now reduce the numbers that we serve through the community health worker model here. So we're going from 700 to 450 program participants. We have now 12 zip codes between Kansas City, Missouri and Kansas City, Kansas. And those are the zip codes with the highest rates of infant mortality that we will continue to serve. Another change in response to that reduction is all of the community health workers now will be in-house here at Nurture KC. We will not be in the federally qualified health centers going forward. We are in the process of hiring some new community health workers, so I think we're all excited about that. And kind of a second prong that's a change this time around is we are to have a community consortium. And what that means is Healthy Start is looking at really the social determinants of health that impact these pregnancies and how we might, on a larger community scale, and so we've hired a key engagement director, and Akia is going to be coordinating that effort. For anyone who's interested in participating in that, please reach out to Akia. She's going to hold her first meeting towards the end of July here. So it's going to be quite quick that we get rolling with that. In addition, another change is that we are to provide continuing education to 250 additional parents in Kansas City who are not within our Healthy Start community health worker caseload. So we're going to work with Promise 1000 on reaching a lot of the families that they serve to offer that education. So we're in a bit of a growth phase here. It's going to be really interesting to see how this next iteration plays out for us. And then one thing I wanted to point out with Healthy Start is I just went through and looked at the grantees. And what I saw was we are definitely an outlier here at Nurture KC. We are one of just a handful of Healthy Start recipients that are a small nonprofit. Most are either associated with a state or local government, generally a Department of Health, or they're associated with a university or affiliated with a hospital system. So I think that really speaks to the work that we do here and our ability to meet the goals of Healthy Start that we've continued to have this opportunity. So what have we been doing in Healthy Start? Well, over this last year, we served 603 program participants and met 90% of the benchmarks that are laid out in the program. We continue to offer doula services, and to date, we've served 54 mothers with doula services through this program. And I think that has been so vital to physical and mental health. And I feel like we've really been at the forefront on that issue. Some of our CHWs have also received doula training. And Marcella, you want to give a wave? Marcella Metcalf, community health worker here, and so she will now get her certification. And we felt like in addition to contracting for doula services, it would be helpful for some of our community health workers to have that experience and knowledge as well to better serve the families in our program. So our top priority for this upcoming year is to offer individual counseling services to those moms in greatest need in our program. This has been a longtime goal of mine and Shannon's, who is our Healthy Start program director. And we really feel the need to take it to that next level. We've offered group counseling for the last few years, but there really is a need for that individualization for some of our moms. So we're looking forward to rolling that out probably late summer. Okay, moving on to our fetal infant mortality review. We are coming up on the 20th anniversary of FEMUR, believe it or not. We're going to be doing an anniversary report sometime in the fall. And, oh, Shannon. Okay. I just shouldn't even breathe on it. There we go.
There you go. Take a step back.
Okay. One more. Okay, thank you. And FEMUR's been quite busy. In 2023, FEMUR looked at 23 cases to identify trends in these fetal and infant deaths occurring in the metro. And cumulatively, FEMUR, the review team, has looked at 396 cases over these 20 years. And I did want to point out one change that we know is coming with FEMUR, and that is the state of Missouri adopted funding just this year to expand FEMUR statewide. So there will now be 10 regional FEMURs across the state of Missouri, one of which will encompass just Jackson County. In our conversations with the state, they are expecting us to help lead the way with the rollout of FEMUR and learning from what our experience and practice has been. So I think it's an incredible opportunity to apply a broader view to what's going on with infant deaths across the state and develop these very local solutions that can be implemented across Missouri to improve those health outcomes. Locally, over the last year, we have concluded our Safe Sleep initiative, Nurturing Safe Sleep, where we worked with area hospitals to get Safe Sleep certified through Cribs for Kids. And what that encompasses is having a safe sleep policy in place, training staff on that policy, providing education to parents, which we know is so important. And so to date, we assisted Providence Medical Center, North Kansas City Hospital, Liberty Hospital, University Health System, and Advent South get that certification. When we started, there were 2 hospitals that had this. We're now up to 8. So that's been a 2-year process that we've now concluded, although certainly we're not done with Safe Sleep. It's a leading driver of infant death in the city. And the way that I see this going is that we next go to doctor's offices and start getting that education going very early, both in the prenatal period and then in the pediatrician's office once baby is born. So looking forward to continuing that work. All right, our Mid-America Immunization Coalition. If it's fall, there are free flu clinics with Nurture KC. And we have several community partners, many of whom we've had for years. And this has been a great service. We do actually do one of our clinics for our Healthy Start participants as well. And it really melds into that priority that Healthy Start has set around immunizations is important to maternal health as well as the infant's health. So some of our partners have included El Centro, Cleaver YMCA, Mexican Consulate, Salvation Army, Kansas City, Kansas Community College, and Donnelly College. And this is a partnership that we've done with Walgreens over the years. So MAC in the community. Maricela Sanchez, who is another one of our CHWs, you want to wave? She actually participated in an educational video that was coordinated by El Centro on the importance of vaccinations in the Hispanic community. And I think this is part of the role that we play in this city is connecting with partner organizations to deliver that broader message. And Maricela did a fabulous job on that. In addition, the Kansas Health Institute launched its ECHO series on vaccines over this past year, and we were able to present on the one dealing with maternal health vaccinations, and that work will continue too. I know that Immunize Kansas Coalition, with whom we partner, is wanting to do an education module on the importance of RSV vaccines, since we are seeing some hesitancy around that. So, advocating on behalf of these maternal and infant vaccines is so important to the health of our families and the work that we do. All right, so Promise 1000. This is the last program I'll talk about today. We are the fiscal agent for Promise 1000, and it operates a little bit differently than we do, but we're starting to converge somewhat. Promise 1000 is strictly a home visiting model. Impact model, meaning there are agencies that deliver services. And so there are 8 area agencies that are part of the Promise 1000 group, along with several other agencies that receive referrals through Promise Network, and through over 7,000 home visits. And I will say that within our Healthy Start program, we are moving more into the home visit space as well. We think that is one of the best ways to engage what's happening, and it mitigates that transportation barrier that some of our families might experience. So look for us to be more in that space. All of our community health workers have gotten parents as teachers training this year. So excited to see what that means in terms of Promise 1000 has been a long time leader in the mental health space and the importance of addressing that. They do that through their Moving Beyond Depression program, where they are screening mothers and providing in-home therapy care for those mothers. And, I just think it's so important as we talk about this topic today that the mental health of the mom not only affects her, it affects the family at large. And it is an issue that must be addressed. It has been neglected or treated as a tangential issue for too long. And it's time that we treat mental health like it is just health. And so that's really what we're focused on today. Okay, so on the public policy front, this was probably the quietest legislative session that I have seen since I've been here. And it's not for lack of bills being introduced, because there were thousands, many of which had me terrified. But ultimately, most of the legislation that we were not supportive of ended up not passing, with a couple of exceptions that I'll talk about here in a moment. But on the immunization front, that's probably where we've seen the most activity over the last couple of years, particularly on the Kansas side. We did see an effort to pass a bill that would have greatly restricted the ability of the State Department of Health to mitigate the spread of contagious disease, would have prohibited quarantines, and even in many cases, public notice that an outbreak had ensued. That ultimately did not pass in the House. And we really didn't see anything else getting the traction that it has in previous years, but we will always be vigilant on this issue. In Missouri, there was a bill that passed that no longer does not allow Medicaid to be used for health services at any abortion provider in Missouri. This is, of course, aimed at Planned Parenthood. And this is a disturbing trend from our perspective. Planned Parenthood often serves as the primary source of healthcare for many of our mothers. And so they have continued to provide those services, but they are not getting reimbursed through Medicaid for those in the state of Missouri. And then there was another bill that had broad bipartisan support that we would have loved to have seen pass, but it did not. And that would have allowed for the treatment of syphilis in utero. It also would have allowed for longer-term contraceptive care. They coined it the Women's Health Bill, and that's truly what it is. I am hopeful that we will see this resurface next year. I think it was really just a matter of time, and so few bills ultimately getting to the floor in Missouri that really kept this from passing. It really doesn't go to what the merits of the issue are, which were very well supported. Okay, so this is one of my favorite parts where we talk about our role in the community. And I'm always happy to say that, yes, we are a direct service provider, but we do a lot more than that. And that's one of the reasons why we hold this meeting. It's to shine a spotlight on issues. And as you can see, we've done several interviews on a variety of topics over the last year, and we will continue to shout those messages because it's just so needed in the city. And then here are some of the civic engagements that we've engaged in over the last years, from community baby showers to with members of Congress as policies are put forth around maternal and infant health. Again, this has long been one of my top priorities for the organization. I think we have an obligation to play this role both in a state level, and that's going to continue going forward. And then here's our board of directors. And as Sebring commented, we did just elect a new slate. So I'm excited to get started with them. And I think we have a wonderful of people who are very committed to this, interested in serving on our board. Please reach out. We're always happy to take on newcomers. And then last but not least, of course, it is the team. This happen. I'm just privileged by staff to stand up, if you will, and I'll do a quick introduction. We've got Shannon Williams, who's our Healthy Start Director, Akia Howard, who's our Community Engagement Director, Marche Hudson, one of our community health workers, Marcella Metcalf, our lead community health worker, Maricela Sanchez, our community health worker. And yes, your name must start with M to be a community health worker here. And not to leave out Michelle Biondo, who is our development director. We've got Gina Hopkins, our finance and administration director in the back, and Erica, there she is. Erica, who keeps all the trains moving. She is our office coordinator. Okay, thank you, everybody. Oh, and of course, I don't want to forget our partners. We couldn't do this work without all the community, state, and national support. We continue to diversify those partners and look for additions to this next year. Would encourage you to follow us on our website, nurturekc.org. We're also on Facebook and on X. Thank you, everybody.
Thank you, Tracy. And let's just do another applaud for the whole Nurture KC, all the work that they're doing. So today our keynote speaker is going to set the stage on maternal mental health issues. We are very excited to have Jamie Belsito, founder of the Maternal Mental Health Leadership Alliance, join us virtually. Jamie's life work has shown a dedication to improving the lives of mothers and families. Jamie, thank you for joining us.
Good morning. I got the note to wear pink, by the way, so I'm very excited about that. Thank you. And thank you, Shannon and Tracy, for being so helpful. I will admit I was ready at 8:50 East Coast time. So that actually worked out great because then I had a little bit more time to, take care of my hair, which is so tough in this humidity, and we're even having our own heat wave here in Boston. So good morning. I am Jamie Zalloway Belsito, and I am the founder of the Maternal Mental Health Leadership Alliance. I come to policy work by way of my own lived experience, and I have two beautiful girls. They were absolutely wanted, planned pregnancies, and I suffered greatly for two different iterations of maternal mental health complications. My background was in immigration policy, incidentally, and I felt that if I myself was having challenges finding supports as a married English-speaking Bostonian native in an area that hails itself as a mecca for healthcare. Oh, let me know when I'm back. Let me know when I'm back.
We can make a quick announcement. So we're having issues with the internet. So if you are logged into the Wi-Fi, if you could log off, I think that would help us and keep Jamie on the Zoom. Okay, back to you, Jamie.
Thank you so much. Any chance you could tell me where my where my screen froze, what I was saying, so I don't repeat?
You had just started with you have your own lived experience, and we didn't hear anything after that.
Thank you so much. So yes, I do come to this by my own lived experience, and I had very difficult time finding support for myself. I have a 14-year-old and an 11-year-old, both girls, both wanted, both planned pregnancies. I'm a heterosexual woman living in the Boston area, and I had private insurance, and again, live in an area that prides itself on excellent medical care. And I unfortunately was not able to find that for myself. So my background in immigration policy, which is another area that we could have our own conference on, set me up to create advocacy and policy improvements on maternal health. And I chose to do that at the federal level because that is my background. So I think NC, pardon me, I think Nurture KC, I'm so bummed that I'm not there today. This run a show is incredible. The fact I get to be keynote speaker, I'm so thankful for. the panel on support for grieving parents, the perinatal psychiatry access program, all of these, the social determinants, maternal health panel, all of these initiatives, they've all been community-based. I just heard what you were saying about your community-based supports. My middle name is Marie, so I think I can fit into the M need there that you were saying. That's everyone that works in this space, but it is from early intervention to home visiting, to access to healthy food, all the stops, breastfeeding, diapers, all of it. We are all leaning in to do our part, and I hope that the work we do at the federal level is part of that interception of getting funding to the state and then to the communities. So with that, I am going to share my screen. And I'm very thankful for, again, for this opportunity here. Give me just a moment. We'll go through the crisis that is maternal mental health. Okay. And I'm hoping that that is up on the screen, hoping that my PowerPoint is up there. It looks like it is. Okay, great. So again, this is the #1 complication of all pregnancy. And we're going to give some facts and figures and kind of go in and out on some very important facts from a policy standpoint as well. So here's me. As I stated before, I have 2 girls. I experience anxiety, OCD, and rage, and compulsive thoughts. Now, these are quote unquote outside of how we think about postpartum depression, which it is a spectrum of challenges. It's a spectrum of mental health challenges. It's also the only temporary treatable and preventable mental health disorder out there. I founded the first ever Maternal Mental Health Advocacy Day on Capitol Hill in 2016, and founded the Advocacy Day at the State House in Boston. And these are also things that can be done going to your city councils, going to your select boards, going to your public health departments, and going to your legislators to say enough is enough and get that support. What is the Maternal Mental Health Leadership Alliance? We are a nonprofit. We are bipartisan. We look to specifically focus on improving the mental health of mothers and childbearing people, with the focus on health equity, positive policy, and health equity. Women's health at all points of our life have had continual declines in outcomes. And when we take a look at that large bucket, then we see our indigenous populations, our African-American populations, our Latina, Asian American, etc. We as women suffer very greatly in a lot of areas of lack of research, lack of access, being charged more for our healthcare services. And then when we take a look at this specific area of maternal health intersecting with mental health, we continue to see that there are issues within the demographics that we need to address. So here are all the wonderful photos of the babies, right? The baby on the Pampers box that's sleeping because they have a dry diaper. And I don't say that to be facetious. I say that because the reality is that although we like to talk about how this is the happiest time in a family's life, and it is, especially when they want to pregnancies and if people are having challenges, and then there's this, right? The dishes, the laundry, the young lady with the seersucker outfit laying on the floor crying is my dear friend and executive director, Adrienne Griffin's daughter, Claire, having a tantrum. She loves to put that in here, right? The food, the messiness, the diapers, all of it, and the lack of sleep. So it's not always the best time. It's the most common complication of pregnancies. It affects 1 in 5, and we say that with knowing who is coming out in screening positive. So I often think that that's probably more like 1 in 3, 1 in 4. And building trust with your communities, building trust with the people that you serve, you'll be able to really make that relationship flourish if you have trust and are able to have that individual say to you, geez, you know what, I'm not feeling okay. And it's okay. They are 1 in 5, as I said, but more likely 1 in 3, 1 in 4. And the reality, the stark reality about this issue is that suicide and overdose combined are the leading cause of maternal mortality. And that is almost across the board. If it's not cardiac challenges, the maternal mortality review committees, and I believe you'll be speaking about those at the Kansas City level as well as at the state level through the Kansas hospital systems. And I think you've got, you have a Kim Brandt, MD of PQC, to talk about how they're able to glean information through reviewing data that's collected during the life cycle per se, medical records when a mom passes away during that pregnant and or postpartum period. This is 88% preventable, if not 100% when it comes to mental health. We are failing as a society when we are seeing moms and families losing their life to something that is the most common complication of all pregnancy. So anyone who's been reading the news, been part of the news cycle, listening to the news cycle, especially us that are in the maternal health space, we know that our maternal mortality rates have been escalating. And again, unacceptable, unacceptable. We spend the most on healthcare out of any industrialized nation in the world, and we have the worst outcomes. South Sudan has better maternal health outcomes than we do here, and they're in the midst of a civil war. And that is unacceptable, and we need to understand what that means and how we can serve at our community level. Always comes back to community. We're gonna have these statistics that give us the ability to work on policy, to give you guys money to get the work done in the communities. That's how I look at this. So we know what we're facing, and here's some stark bar graph information to confirm that. Again, the breakdown within the maternal mortality rates here. Unbelievable. Per the CDC, we see this red line that we've highlighted here, that mental health complications and conditions are the highest, the biggest cause of pregnancy-related deaths. Again, unacceptable. Mental health conditions are the leading cause of death for white and Hispanic women. The leading cause of death for Black women is cardiac and coronary conditions. And there's research being done. We continue to have these conversations in the room where conversations about women's health are happening. Does the impact of racism, this expectation of being Wonder Woman, being the one holding a lot of responsibility, and I'm speaking on behalf of information I've seen as being privy to conversations in circles of women of color, to say, does the mental health component actually lead to physical health complications? And I think we've all seen that manifest in certain ways within our own communities. And so does this actually impact the cardiac health of Black women? And the leading cause of death for Asian women is hemorrhage. So again, a lot of food for thought here. Vocabulary, we are using women as our point of reference in this discussion. We strive to use inclusive language whenever possible, and really want to emphasize the fact that this is an issue. Women's health has been drastically overlooked always, and we are finally seeing traction in maternal health. And so we do appreciate the fact that some folks don't identify with the word mother, but that is where we will be using our vocabulary and our language today. Postpartum depression, right? The thought of, oh, someone's just crying, they'll get over it. Postpartum depression is sadness. It can be rage. It can be obsessive compulsive disorder. It can be anxiety. It can be not sleeping. It can be a whole host of things. And these are our vocabulary words that we use: postpartum, perinatal, antenatal, perinatal mood disorders, perinatal mood and anxiety disorders, perinatal mental health disorders. They're all an iteration of the overarching maternal mental health conditions. So the time frame we currently refer to is from the conception all the way through the first year of postpartum, because manifestations of any of these mental health disorders can occur at any time during this arc of pregnancy through first year postpartum. And incidentally, looking into the second year as well, but we'll have to follow the data on that. Anxiety, depression, bipolar, obsessive compulsive, PTSD, friends. If someone goes in thinking that they're going to have this holistic experience of having their child without medication, I'm painting a very fluffy picture right here, and they end up in labor for 40 hours in an emergency cesarean, we need to take that into consideration, what that looks like. Also, for women who go in and don't want any interventions, don't have an advocate, and are facing challenges that we see in our Indigenous community and our Black community, potentially dealing with not listening to the mom, not listening to what they want to happen, having interventions. We need to be mindful of the experience at the hospital, or whatever the experience is, where that is, and how that can affect the mental health of the new mom. Substance use disorder, that is a disorder. We used to look at this from a criminal lens. We now have to look at this from a family lens. And there are abilities for us to take care of both mom and baby and keep the family unit together and give them the supports that they need for keeping the family unit in one place together. And then psychosis. This is a smaller percentage, but can deeply affect the health and wellness of mom and family. And we've seen in the news can lead to very dire consequences. Again, it's not just postpartum, it's not depression. Individuals, this pie here talks about where individuals start to deal or feel these challenges within the maternal, within the perinatal period. And you'll see it's almost 1/3, 1/3, 1/3. And 25% of individuals who experience these complications continue to have depressive complications if not taken care of, right? If not talked about, addressed, even 3 years postpartum. And I think that we need to also consider this when we're talking about family planning. If anyone out there is talking about does family planning or speaks about that with their constituencies, what does this look like? Really take out the shame, take out the stigma, let folks know they're not going to be penalized, let folks know that there's supports out there, let folks know that, and you're going to talk about all of this, what's available in Kansas City, what's available in Missouri, talking about that access line. How do you get your clinicians or anyone who's working with moms to get the information to let them know they're going to be okay? Peak onset, 3 to 6 months. This is very important when we are also looking at our Medicaid population. I'm not sure about Missouri. I hate to say, I don't conclusively know if Medicaid expansion happened 12 months postpartum, but those initiatives are so important to make sure that women are kept healthy and whole. If they're taken off insurance 60 days after their baby's born, and we see that this peak onset's 3 to 6 months, we need to be looking at how to take care of people and keep them healthy. And the suicide part of this, 9 to 12 months, something very important to think about, something to continue to educate parents and families about, and let them know they're not alone, that there is support, that this is a temporary time, and that there is a way to get them the help that they need. It's biopsychosocial and hormones. We see that the drop off of HCG goes down during the pregnancy, and that progesterone, the moment the baby's born, boom, down, and then the oxytocin during lactation, and the hormone fluctuations. So there's a lot going on. Those of us who have been there know that. Those of us who are working with the families know that. Again, letting folks know it's not just you. There's a lot going on here, and there are reasons why. We want to be very mindful of some of the signs and symptoms. It could be all of them. It could be one. It could be a handful. It could come on 3 months, 6 months, 9 months. It's all of the things that we need to be speaking about. Issues with the partner, issues with sleeping, physical issues, personality issues, thoughts. That was the personality and thoughts and sleep for me were huge triggers. I had a baby that was allergic to dairy and soy and eggs and all the things. We see a lot of allergies these days. And if the mom is eating food with those allergens in them, the baby can continue to be upset by those. So these are things we can be mindful of when we're supporting our communities, and how to identify signs and symptoms. Individuals with a history of mental health conditions. Anyone who's gone through multiple potential losses, stillbirth, you're talking about grief. Thank you so much. Failed IVF, failed surrogacy, failed adoption. These are so important to be thinking about that when we're speaking to our parents, because even if they finally have this baby and it's what they wanted, there could be triggers as to why they're experiencing mental health complications. Parents who lack social support, which is you guys out there being that social support, individuals of color for reasons that I very topically went over, individuals facing economic challenges, parents with NICU babies, our military mothers and spouses, which is another area we're leaning in on policy. Citing that Black mothers are 2 times as likely to experience maternal mental health conditions and less likely to get treatment. And this is more conversations of how do we get access to those in our communities that may be leery of certain medical systems or systems as a whole. And we need to consider at every point, what are those social determinants of health? What are the bias and racism aspects within the support systems that are there, within the hospital settings, et cetera, et cetera? Are they there? We need to listen to women, chronic stress, and then barriers on things that we take for granted, time off, assuming there's another spouse there to help with the load, or a parent. How do you take time off at work? How do you compensate if you're getting paid for short-term disability, which I didn't know pregnancy was until I took time off, that it was short-term disability, or vacation, my favorite, transportation, and then childcare. There's a lot to take into account here. Some more facts and figures on taking a look at what these depression symptoms are by way of quantitative data. And again, it's a perfect storm. So the impact on the mom are all of the things that we've already gone over. And I'm gonna highlight that bottom question is competency of an individual as a parent. This is the worst feeling in the world, of which I suffered greatly from. I'm not worthy to be my child's parent. I shouldn't be a parent. If I just disappeared and went away, my child would be so much better without me. That is the brain giving false information. And this is where people start to go down into a black hole, as what I call it. And any supports, if you're doing home visiting, or if you're a new mom yourself, or if your sister just had a baby, your neighbor, or you're a nana or a meme, or whatever it is, just check in. How are you feeling? That's great. Don't look at Instagram. Forget about Facebook. Take care of yourself. If you get through the day, everyone's safe. Everyone's been fed, and everyone has, access to what they need to get through the day, diapers, food, etc. You're doing a great job. It's very, very tough. Just let folks know they're not alone, and take a look at what's available for those who are dealing with substance use. They are not alone, and there are programs out there specifically for maternal health. I'm giving a lot of negative, like what I will call Debbie Downer comments here, but it's just for us to be educated, to understand that it can impact the infant's weight. It can impact preterm birth if individuals are depressed. It's excessive crying because the baby's picking up on the stress of the parent. And there's actual data now being gathered to show the long-term complications of mental health issues on the child in the early stages of their elementary school years into their early teen years. And so this is the ripple effect of not taking care of folks from during pregnancy and the initial stage of becoming a parent. You guys are doing the work at Nurture KC, and it is so amazing that you're out there in your communities. Impact on partner. This is June. It's father's perinatal depression is cited during Father's Day, right? Father's Day was this past weekend. This is very interesting. There's more and more conclusive data to show that 1 in 5 fathers can also experience or will experience anxiety or depression. We at MMHLA are actually having a webinar on that. If you go to our website, www.mmhla.org, you can sign up for that webinar. And there's a host of other webinars as well, talking about what it's like to be an individual with a disability, what it's like to be in the military, talking about the racial and bias impacts, and a lot of information's out there for you to look at your leisure. Untold costs. When you're talking to your legislators, I hate to say this, money talks in a society like we have here in a capitalistic society. $14.2 billion annually lost, and that was in 2019. I'm sure post-COVID, it's even higher. That's an incredible amount of money to be lost. That's readmissions to the hospitals. Psychiatric readmissions to hospitals, actually the #1 cause of readmissions for a new parent. And then bringing the child to the ER because the parent feels like something's wrong with the child. And generally 9 out of 10 times there's nothing wrong with the child. It's because the parent is so hyper-focused, so concerned, so full of anxiety. This is lost wages, productivity, all the things. It is, again, something that we can nip in the bud and help reduce those costs and let parents feel safe. Temporary and treatable. Isn't that incredible? It's the only mental health condition that is out there that is temporary and treatable. I am proof of that. I have the best relationship with my girls. I have a wonderful relationship with my husband. It took a long time for me to feel okay with me. And that's usually where it starts and stops, is with the parent. And my children are no worse for the wear of what I went through. They were great. I wasn't feeling well. And that's the reality of maternal mental health conditions. And we're going to talk about the evidence-based preventions that you guys have right in your own backyard. Steps to wellness. We have some phenomenal fact sheets on our website. Again, mmhla.org. You can do the drop down on the fact sheet. I love this self-care. We always talk about self-care, self-care. You know what? Go do someone's laundry. Go vacuum for them. Get someone some help in there. Let that mom sleep. Give that mom some time to go for a walk. Go hold the baby. You know, food trains, so to speak. Get those families fed. These are all things we can do together. It's really rooted in community. Let moms and new parents know that they're doing a great job, even if they don't feel like they are. You know, make sure you pick up that phone, text them, call them, go by the house if they are okay with that. And just let them know that there's information there. There's all sorts of therapies that are out there. Also, let them know they can speak to their doctors about taking antidepressants or any other sort of medication. It's available. It's been studied, and the National Institute of Health has this information to show that medications, if they are managed with their doctor, are available and are safe. There are different evidence-based prevention models that are available that we have on our website at mmhla.org. And a postpartum plan. If you're going to plan your birth, let's plan what's going to happen after. So this is also available out there. And resources and connections. You'll hear about these today, the MMRCs, the PQCs, and the AIM bundles. Please, if there's anything you do, as I conclude my speech keynote here, write this number down. 1-833-TLC-MAMA, 24/7 hotline that we worked with Congress to get implemented. It's served over 35,000 families at this point. It's text, it's bilingual, it's available to anyone. And I have old figures here. I'm so sorry to say, launched Mother's Day 2022, and it's helped over 35,000 families. Put that in your pocket, get the information from HRSA. You can get handouts, little cards, magnets, all the things, put it out there. Postpartum Support International as well. They've been around for almost 30 years. They have warm line on the ground, boots on the ground, state chapters, training, all the things, psychiatry access programs. You're going to hear about yours today, and intensive treatment programs, which doesn't look at, well, you folks have one outpatient in Missouri, and then there's an inpatient in Arkansas. And I did want to say, think about this. How comfortable are you discussing mental health with your clientele? If you need support, we're here for that. And please, again, come join us. However we can be a resource for you. Sign up on our newsletter. We have information going out all the time on trainings, conferences, what we're doing legislatively. Sign up for our newsletter. It is an honor, a joy, a privilege to dedicate my life to making sure that no one suffers the way that I do, that we do not lose one more mother to a preventable, temporary, and treatable condition. I am so grateful for the opportunity to speak this morning. I wish I was there in person. If you ever come out to Massachusetts, please call me. I will take you out. I know where the real lobster rolls are, and I will bring you to eat the real good seafood, and you will have a wonderful time in Boston. And I want to say thank you so much to Tracy and Shannon. You guys are awesome. Have a great day. Enjoy.
Thank you, Jamie. That was incredible. Oh, so sorry.
I'm excited.
Okay, okay. All right. Jamie, thank you again. And we are going to 5-minute break right now, and then food, use the restroom, and we'll be back a little before 9:30. We're going to start to head back to our seats. Okay. So I would like to welcome Renee Delatorre, Brianna Bradley, Tricia Rouse, and Erica Bailey to discuss the support services that are in place for parents who are grieving from fetal or infant death.
Okay, thank you for joining us, ladies. Today, we are going to learn about the supports that are in place for parents that are grieving infant or fetal loss. We know that the loss of a pregnancy, the death of an infant is not only devastating and sad, but it can also be very hard for parents to navigate. We're also very fortunate to have a mom present who will share her own story of loss in an effort to honor her son and prevent the others from suffering the same loss. Graham, we're going to start with you. Can you tell us, what does bereavement support look like in the hospital from both the healthcare perspective and the bereaving family perspective?
Hi, thank you for having me. From the healthcare perspective, it is important that we have comfortable, competent caregivers that are providing care to our patients. And this doesn't just include nursing or even the physicians. And I'm not talking competence in their medical knowledge. I'm talking about their competency and their comfort level with death. And a lot of physicians, a lot of nurses, especially new grads that haven't experienced this situation, are very uncomfortable. And it has a way of presenting itself directly to the bedside. So it is important to provide even our staff information, knowledge, education about how to even a quick, hey, what not to say kind of thing. I sit down with chaplains on a quarterly basis, and that's one of my things is let's not say that you have an angel in heaven. So providing that information, having that in their toolbox helps to provide some confidence and that fear in approaching a patient who's experienced a loss or her. We also, as nurses, psychological care, mental, emotional, spiritual. Thankfully, we have spiritual wellness available at most facilities. And if not, you can always offer to have someone come in from their own personal support, whether it be a church or an organization of spiritual focus. We also have social work. Those staff are very important in providing additional resources, financial support, things that they have knowledge that I don't, and that is very helpful. Nurses become, again, not only just physical caregivers, but I also became a very, very good photographer of non-living babies. And that can be impactful from a patient perspective. I also became a legacy creator or a memory maker, providing all types of memories to put in a box or some type of a memento collection that helps to remember the baby and that time together. So I attend international conferences where we share resources, we share memento creation. There are things nationwide that are always improving in mementos. And, when I started 22 years ago, it was still a stigma. It was just still a stereotype. But now, well, I have no boundaries. That's not a surprise, but I might find a picture of a baby that I took on. It's not something stigmatized as it was. Now, you can argue whether some of it's excessive, but that is what we want our moms to do, is talk about their baby, share their baby, say their baby's name, remember their baby's birthday. And that's what we do there in the hospital. It is often that we provide long-term follow-up, typically for a year, at least at St. Luke's. And that is a consented program led by nursing. It's just a very cordial, hey, I'm thinking about you, you're doing okay, do you need resources, such as that. And as far as the patient perspective, they get put into a situation that they didn't ask for, and they don't have a leader. They don't know what to do. And so from my perspective as a nurse, you are their hand to hold. They look to you for support, direction. Even if to answer a question, they'll look to you sometimes for that information. Social work and spiritual wellness and physicians provide a lot of support as well, but there are things throughout the community, such as compassionate caregivers that come in that are patients previously that are trained to come to the bedside and kind of be that advocate. Because as a nurse, I have to split my time effectively, because if she is bleeding, I can't focus on taking pictures of the moments of the baby's only moments of life. So having that, what do they call it? It was the compassionate when the previous patients come in. I can't find the word right now, but those people can provide a lot of support when charge for bereavement photography. That's called Now I Lay Me Down to Sleep. That has been very impactful for situations where it is most ideal. And then obviously my big thing is providing a strong foundation for that mom in the hospital to then go forward and use what we gave her to move through grief, because it's not temporary, it's lifelong. And if we can provide her with that strong foundation, then resources that Trisha will talk about help her through that course. So
thank you. That's wonderful. Renee, I know that you work really closely with the families, but can you tell us specifically what are some of the hurdles that the bereavement staff encounter? And that could be cost, mementos, policy setbacks.
I would say one of our biggest hurdles is funding. We're a grant-based organization, and most of the staff that's here in the KC area is very, very part-time. So I'm about 10 hours a week. And so there's not enough money and not enough time to reach the families like we want to. There is a lot more funding in the St. Louis area than what we receive here in KC. And there's lots of funding for safe sleep education, but not as much for bereavement support. So it's just finding those grants to be able to provide bereavement support for the caregivers. Also, here in the KC area, we serve Jackson County, Clay, Platte, Cass, Buchanan on the Missouri side, and then Wyandotte County, Johnson County, Leavenworth, and it's one person that's trying to reach all of those families. So that's a huge barrier, but that goes back to funding. And then when we do get referrals for families, because the area is so spread out, it's really difficult to find place where we can do support groups, because the families have huge barriers to access. So if we plan a support group in Johnson County, our families from Independence are typically not able to get there. So it's trying to find different locations where we can meet the needs of all of our families. We did try virtual support groups during COVID. At the beginning, it was really successful, but I think caregivers were really missing that one-on-one contact, because peer support is a huge part of what we do. We want to match families with someone who's a little bit farther down the road on their grief journey to kind of help them along. And so when we're not able to meet in person and not able to get families into our events, then we're not establishing that peer support connection that we need. Another hurdle is referrals. We have a really fantastic relationship with the Jackson County Medical Examiner. I typically will get a referral from their office within 48 hours of an infant loss. So then I'm able to send out our bereavement support information and get that family connected. Where in other counties, such as Wyandotte County, they work on a coroner
program instead of a medical examiner, and they choose not to collaborate with us. And so I typically, the only referrals I get from Wyandotte County are from service providers, home visitors in the area, things like that. The Johnson County Medical Examiner does a great job of sending referrals as well. So that's kind of a barrier. How do we reach all these families and so many zip codes with lack of funds and lack of time? So those are, and there's been each of us, my predecessor lasted about 5 years. I'm getting ready to transition into a new position. I've been bereavement support for about 5 years. I'm transitioning to community outreach because it's emotionally exhausting to, you want to be there to support these families, but you also have to focus on your own mental health as well. So that's a huge barrier too.
Thank you very much. Erica, we would love if you would share your son's story with us.
Well, let's see his picture while I'm talking, Andy. I was pregnant for the first time ever in 2019, newlywed, the dream, with my first baby, my son, Rowan Osborne Bailey. It was a very healthy and low-risk pregnancy until the last weeks when I noticed that his movements had slowed down. I was not educated on changes in fetal movement. I wasn't educated on stillbirth. It wasn't even a blip on my radar. I thought, I'm healthy. I got past the first trimester. What was the worst thing that could happen? My body and my baby know what to do, right? Fortunately not. So when my son's movements changed, I never reported it. I went to Google instead, and I read a lot of misinformation, like babies run out of room in the third trimester, and babies slow down before they're born. Of which are not true. Even though I had these maternal instincts, these alarm bells going off, blaring at me, I quieted them when I went online and, read this misinformation. My last appointment was at 38 weeks and 5 days, and totally normal, heart rate check, belly tape measure check. I was never asked open-ended questions like, how is your baby moving? Tell me about your baby's movements. I was asked, is your baby moving? And he was. He was moving a lot slower, but I didn't say that. I thought, he's running out of room. I'm going to go into labor soon. The next day, I vividly remember a session of wild and forceful movements that were not his normal. But being a first-time mom, I thought, oh my gosh, am I going to be going into labor soon? And that was the last time I felt him move. The following day, 39 weeks, my mom had just flown in to be here for the birth of her first grandchild. I woke up and he still hadn't moved. So I thought, well, I better go into the hospital. Actually, I messaged my doula. I did have a doula. And she said, maybe he's sleeping. But you should probably go in just to check. So my mom offered to come with me, and I took her up on it. I told my husband to just go to work because I'm just going to go in and they're going to send me home. It's going to be fine. And that's one of my biggest mistakes or regrets. So we went into triage and was told, well, first of all, the nurse comes in, cannot find a heartbeat. So she gets the on-call OB to come, and we're in the triage bay. And I remember there was another family beside us through the sheet, and how traumatic it must have been for them too. But the on-call OB has the ultrasound machine, and there's an image of my son's body on the screen. And she said, there is no heartbeat. Look, the heart is not beating. There is no heartbeat. Can you see? Yes, I could see. So that was the moment.
the trap door opened up underneath of me and I felt like I was dropped into a hell that I would never escape, that I didn't even know existed. I still had to give birth, still had to be induced. I was told that I could go home and come back, but there's a chance that my son would look less like himself. So what kind of choice is that? That was very traumatic. So we decided to go induce the same day and I gave birth. And no hope for any answers. Immediately when we left, I felt huge regret that we did not get an autopsy. And when you don't have answers, you blame yourself. And I blamed myself, even though it wasn't my fault. I know that now. 6-week postpartum appointment. I was told it was not necessary, which made me feel even less like a this but I demanded one. I still want to have a at 6-week postpartum appointment. I was asked by my doctor's nurse, who had seen me my entire pregnancy, how my baby was doing. So I was completely rattled. And then the appointment went off the rails after that because I was so before COVID, basically. So my husband risk for maternal death because he's checking on you. So months later, wasn't my style of grieving because I did it. I went to every appointment. I read like 12 pregnancy books. I listened to all the podcasts, but so they deserve the same, or I would argue better care than as the parents of living children get. So thank you.
Thank you, Erica. Richard, I want to ask you this last question. what support is offered to the community in an outpatient setting for families that are dealing with this kind of loss?
Sure.
All right, thanks, Brittany. And hi, I'm Trisha, and thanks for allowing me to be part of the panel today. So I am the bereavement coordinator at Maternal Health, Shawnee Mission, and am grateful that that position exists, which allows me to kind of do a lot of work in the community and tap into a lot of the resources that we have here right in Kansas City. So when we have a family who delivers with us or contacts me that has had a loss in the community, I keep a running list of support groups available in the city, and that so they know what's out there, because I don't assume that they're going to want to come back to Edmond starting up their group again. And then you made me mom, Amy Bond has her group here in the city as well that meets the third Thursday of every month. And then Bloom, up in North Kansas City has a group on the first Thursday of every month. And so those groups are, included in that as miscarriage, stillbirth, termination for medical reasons, infant loss, all of it together. We welcome everybody into those groups. And so there's not any barriers there. I also keep a list of online groups. So I've been involved with a lot of the organizations, Postpartum Support International for a number of years, and then Star Legacy Foundation as well. Star Legacy Foundation, I facilitate 2 support groups for them online, but they have free online groups every week of pregnancy loss. They have a grandparents group. They have groups. They also have parenting after a loss, which is a great group as well. And then they're starting early loss group this summer, and groups as well. And PSI has a lot of loss groups. I wrote down some of them because I feel they have a Black Moms Loss group, early pregnancy loss, fertility challenges, pregnancy after loss, and groups and the workshops. There's a few, but most of them are free. Postpartum International and Star Legacy, theirs are all free. And so I feel this practically, I had a loss myself 17 years ago to what I do. And I will say that this is one thing that I'm excited to see that has changed over 17 years, is that ladies.
I would like to thank Erica for sharing your story and straight that a lot. And I just conditions are the leading cause of U.S. over 23% of maternal deaths. Our next panel will discuss the new perinatal psychiatry access program for providers. Please welcome Bender, Kimber, and Horn-Mueller.
Space, but. Well, ladies, we're thrilled to have you today. Panelist is going to be virtual, so we'll wait to get Dr. Brandt up here on the screen and then we'll get started. They're getting that figured out. We'll go ahead and do introductions with our panelists here in person. Dr. Biter on the Kansas side. And we have, well, she dropped again. What I'm wanting around kind of an individual and a community level about what's going on. I'd like to zoom and look at what initiatives are funded right now and how that's come down to our respective state and city levels. And so I think, Dr. Biter, we're going to start how these, why they were established. Yeah, so kind of frontline healthcare professionals, kind of including the capacity of color, kind of diverse providers across all different areas of healthcare who are able to kind of act with women in a way that is culturally and clinically competent. So this kind of started with the Massachusetts Child Psychiatry for Moms and was we're going to make more money available for other states that kind of have access to these programs as well. So in Kansas, KDHE, and then the Kansas Maternal and Child Health Title V program, well, to make sure I got it right. We were already kind of working on some of the and trying to expand access in the state of Kansas already and trying to improve screening practices and things like that. And so in 2018, when Congress approved the expansion of these programs for other states outside of Massachusetts, Kansas kind of saw that opportunity and jumped on it and was able to be programs to be federally funded to expand that access. And then in 2021, when I moved back to Kansas, we were able to add the perinatal psychiatry expertise for our case consultations through the access line. Great, thank you. Dr. Brandt, can you hear me?
Hi, I can hear you. It's cutting out a little bit.
So can you talk a bit about Missouri's PPAP, kind of what the structure is, what your goals are, and specifically, I know they geared in large part for providers that as well. Can you talk about that a little bit?
Yeah, so sorry I wasn't able to be there in person today. I had some car issues and didn't really want to drive across the state without air conditioning in my car, so I apologize, but happy to join you guys virtually. Missouri just launched our perinatal psych access project. It's called the Maternal Health Access Project in April of 2024. So we are a very young program compared to the program that Kansas has. I will send you a copy of a flyer, Shannon, and if I'm able to put it on the screen, I will put the screen up there for registration. Our project is funded by the federal government through HRSA, and then we also have some funding through the Missouri Department of Health and Senior Services. Where this project idea came from was I have been on the Pregnancy Associated Mortality Review Board in Missouri since about 2018. And over time, we have seen increasing numbers of maternal deaths related to substance use disorder and overdoses, as well as suicide. So the state was able to put out reports, which luckily got fairly well publicized. And over the last, I would say 2 years or so, Missouri has really made it part of a larger goal to improve maternal mental health and access to treatment for substance use disorder and mental health, understanding that it is a leading cause of death in our state, and it's an area that we could really use a lot of improvement on. Our project is certainly, we have psychiatrists that staff the line and can provide, very specific recommendations about diagnosis or medications, dosing of medications, the safety of one medication versus another in pregnancy. But we also, one of the big goals of our project is education. And so because of some of the expanded funding that we got from Department of Health and Senior Services, we're going to be doing a lot of trainings for not just providers, not just medical providers like midwives or physicians, but pretty much anybody who touches life in a professional way of a mom can enroll in our project. And while we understand that, a doula isn't necessarily going to be prescribing a medication or may not have a medication specific question or a treatment question about a mom, we want people to be able to have access to expertise, not just about medication and treatment, but if we can help navigate the system and help you get that mom to the right place, then I feel like we are doing our part to really help spread the knowledge of maternal mental health and substance use disorder, because it matters that our providers are educated about it, but it also matters that everybody the patient has a touch point with understands, that mental health and substance use disorders are treatable, and, even just there are medications that are safe and you shouldn't just stop all of your medications. And just to understand and emphasize the importance of maternal mental health and well-being, which includes, continuing to get care for any mental health issues that someone might have going into pregnancy, as well to increase awareness over those who may be diagnosed during pregnancy or postpartum. So that is just briefly a little bit about our goals and our project.
Thank you so much. Corey, I'm going to turn to you at a systems level. Can you tell us a little bit about some of the initiatives within Women's Health Services that are specific to maternal mental health?
Yeah, so we're doing a lot as an organization to really focus on mental health, but especially in the maternal world.
We did hire a couple of years ago a psychiatrist that is pretty much specific to perinatal and women's health. We've also added in the last year a PA. Which to assist because we can't continue to see the needs of women during, pre-pregnancy, even through that first year of postpartum. So that's one of the things that we want to continue to expand. We do integrated behavioral health services within our clinics, especially with our MFM providers to help that population of patients, which actually was something that patients said that they wanted. So it's basically OB and the mental health appointment going on at the same time. And it's really done some great things. We do Elevate, which isn't specifically from maternal mental health, but it has a component. So it's a group prenatal care that we're focusing mostly on birthing people of color, but getting in that community, that group, making where they meet just like they do in a pregnancy every month, then every 2 weeks, then every week. And it's a community source and a group that works together and they even see after. So at the end, when some of the birthing people have given birth, they'll bring their babies back while some are still pregnant, and they're talking about their stories that gives them that postpartum care where they're talking to the provider, but also that sense of community within the group that they're working with. We're looking at substance use disorder. We are managing it inpatient. We wanted to really focus on that for outpatient because, as you know, substance use, mental health is the leading cause, I guess, for white and Hispanics, but it's a leading cause of maternal death from day 43 to 1 year. So how do we focus on that, getting substance use taken care of during pregnancy and then continuing that out? We got a grant funded for 5 years that's going to help us with our screenings. So it's really going to screen people of color for PTSD, trauma, things like that that have occurred to try to assess the limitations of like our screening tool that we'll talk about a little later. So that's another thing. And then for the staff and physician side of things, we're really focusing on education and training, the comfortableness of having those conversations when moms maybe aren't feeling right or things are going on. So really getting mental health first aid to all of our staff and assist to all of our staff to make it more comfortable with moms feeling like she's not feeling right, to have those conversations and to open up the dialogue. So trauma informed is taking a big place in our clinics and our institution to really help the and staff and the patient people through their mental health.
That's great. Thank you. And, one of the issues that we've been talking about is the importance of just incorporating the mental health side into general health. Great to see what you're doing. Understanding that providers reach out to you when they need assistance. Do you see this moving in any direction where you're contacting various offices? In other words, providers educated enough to even...
Yeah, that's been a big focus, especially over the last grant year. We brought in a OBGYN onto our team, and so she and I do a lot of collaboration together, and we've had a lot of success in the two of us kind of going out together and meeting with especially OBGYN practices when we're kind of coming as a united team, and especially having an obstetrical provider kind of with us, talking to them about why they should care about mental health has been really helpful. So we do go out into OBGYN offices. She's done a lot of kind of reaching out and networking in that way. And then Caitlin, our wonderful social worker over there who works for the line, she's a resource and referral specialist. She also does a lot of outreach and kind of networking and talking with across the state of Kansas, anybody who's, as Dr. Brandt said, touching these patients in any way. We are this year, we have built in to this, like I said, this new grant cycle a bunch of in-person trainings. So we've got, and then in July, we have one in Wichita. And in August, we have one in Hayes. And so trying to kind of hit the different parts of the state where we're doing full day in-person trainings for how to have these conversations open and warm and not threatening or scary, and also how to be comfortable, like when people actually screen positive for things, right? Like what to do with that. And so trying to do some education with that. We're doing some education for like how to bill for these services, right? Like how do you actually get reimbursed for screening people, those kinds of things. Some teaching on like, okay, first line medications when somebody screens positive for depression, when you've got somebody with bipolar disorder who gets pregnant, you're a rural family medicine doc, you don't have a psychiatrist here, like how can you actually manage those things? And so everything from diagnosis to treatment to getting reimbursed for screening to like how to get comfortable having those conversations. And so that is something that we have on the calendar for this year and that we're really actively working on, kind of physically going to these parts of the state that it's not so easy for them to see us in person every day, to make sure that we are accessible to them as well.
Okay, thank you. And this is really a question for all of you, but I'll start with Dr. Brandt. Just going back to the issue of screening, are you utilizing different screening tools? For instance, there are some based on race and gender, or are you finding that providers by and large are using a universal screening tool that might not capture what they need to?
It's a great question. And I think honestly, it's a moving target. And I will say that where we are now, at least in the state of Missouri, we do not have providers that are doing any universal screening, like it's not mandated. So I have to say, I'm, really trying to kind of meet people where they're at in terms of where they're, if they're already using a certain tool. Certainly some of the electronic health records have certain scales that are already built in and are already somewhat accessible. And there is luckily some growing literature on the use of some of these scales and screenings, and there may be better tools for sure out there for moms, particularly those who don't have cultural have cultural differences from what these scales may have been designed around back in, like some of them are from the 1980s and things. But screening is really a starting point. And so, I mean, I'm happy to talk with a provider, an organization about what their current tools are. If they have current tools and are wanting to upgrade those tools, that's great. But at least in the state of Missouri and even in my own organization, we are still kind of struggling to even just get something like an Edinburgh or a PHQ-9 done consistently during a pregnancy or postpartum visit. So if somebody is screening at all, I am very excited. And that's the first step. But I don't want to say I'm not optimistic. I am. There's just, organizations coming at this from different stages of knowledge and change. And we'll certainly, part of our project is wanting to, figure out how we can reach more patients and providers and how we can become more accessible and relevant to their practice. So we want feedback from everybody about any suggestions or ideas you might have and how we could do better.
Take this Stress that's adding really that according to is that we've been asking people to do like screenings instead of one screening. And like Dr. Brand, wonderful resources when people are willing to do it. And they're really excited. Like, yes, with this context. Anything at all. Shorter breaks and we're
Hi, and thank you, panelists.